Emeritus Chairperson, Professor Rahul Sir, respected senior faculty members, colleagues, and my dear students. I take the privilege of presenting my department's overview in brief to all of you, before we proceed for the today's CCR. In alignment with our commitment to serve the humanity and to deliver the patient-centric emergency care, our institute pioneered the postgraduate program within the Department of Emergency Medicine in year 2020. We are the first in the state in North India, apart from the central institutes. We are highly obliged and we are so very thankful to our institute's management to start with this emergency medicine program in the very first year. We are admitting 2 residents annually, and at present we have faculty of 3 members, 6 PG residents, 4 casualty medical officers who are working round the clock, 1 non-academic JR, and last year our first batch graduated from this institute. I am glad to inform all of you that my first resident from this institute, from the emergency medicine department, Dr. Nikhil Sharma, he has topped the university postgraduate exams. We provide round-the-clock services across all specialties and subspecialties with all the state-of-the-art infrastructure available to us. We have a dedicated resuscitation area with all the equipments to deal with the critically ill patients, including trauma and non-trauma. We have an emergency OT running throughout the day with all the facilities. We have emergency area with red beds, which includes 6 emergency ICU beds to cater the emergency patients who come with an emergent condition, and if we are not getting the space in the ICUs above, we keep them in the emergency ICUs. We have this, apart from this, we have 20 more beds. So this total counts to around 34 bedded emergency in our hospital. Our PG students, they have access to all advanced diagnostic modalities and therapeutic equipments to deal with all critically ill patients round the clock, and these advanced imaging facilities such as CT, MRI and X-ray machines, they are available in the emergency area only. Apart from that, we have a mobile emergency X-ray machine and point of care testing also available to us in the form of ABGs, ECG, this cardiac panel, urine routine microscopic. Apart from this and this coagulation profile, and above all, we have our own dedicated ultrasound machine to deal with the critically ill patients, to intervene at that moment and save their lives. My faculty, me and Dr. Chetan, we are involved in all life support skill training programs which are being run by our institute, like Advanced Trauma Life Support Program, Advanced Cardiac Life Support Program, and in collaboration with the critical care, we have also done workshops related to this ECMO, CRRT and ultrasound. Some outreach activities which we have been performing since the inception. We have been giving the life support skill trainings to the police personnel, to the students beyond our institute, that is to the JECRC. Beyond our city also we have gone to the different institutes outside and to the public awareness programs which are being done during our awareness programs being done on the emergency day, World Emergency Day, and on the World Trauma Day also, to our people who are there in the lobby and outside also, to the public outside this institute also. So important highlights of the year. So I would say that I am impressed to tell you that around 33,000 patients, which include 20 to 25% of the trauma also, we have been dealing with them. Last year this was the number, and from this 9,900, which include to all the specialties, were admitted from emergency after the optimization. Total number of patients which were treated and discharged from the emergency were around 20,000. And I would like to highlight over here one important, very important aspect is the ROSC achievement. ROSC is return of spontaneous circulation when a patient comes with the cardiac arrest. It could be because of the in-hospital cardiac arrest or out-of-hospital cardiac arrest patients who are coming to the emergency and we are performing the cardiopulmonary resuscitation. So last year it was around 90 patients on which we performed this cardiopulmonary resuscitation process, and 66 we could say get the ROST. And out of the 66 who went to the cardiology unit, most of them, they were around 20, and out of them 11 were those who were discharged from our hospital without any focal neurological deficit. So that is very important to get that ROST achieved and to get the patient back without any focal neurological deficit to the society, to the community. Now coming to the procedures which we have been doing in the emergency hours, the list is not exhaustive, but only few of them which I will be telling you is that last year we did thrombolized around 15 patients who presented to us in the window period in acute ischemic stroke. We are performing around 20 intubations, 41 intubations per month in all critically ill patients. These are not elective patients for us, these are all critically patients which include trauma and non-trauma who come with a very unstable condition. So this has been done. A number of central lines along with the HD catheter placement is 8 per month. To keep our emergency department pain-free, we are going towards this to keep giving the blocks to the patient so that they do not have pain, and the number is around 10 per month. The intercostal drainage to trauma and non-trauma which we have been giving is around 4 or 5 per month. The number of fractures which we ourselves reduce and the joint reductions which we have done in the last 1 year is 12. And above all, this surgical cricotherapy, last 1 year we have performed 4. This is very important procedure for the emergency resident to learn, because if you land up in a scenario where you are not able to intubate and not even able to oxygenate the patient, and you have given some muscle relaxants also, then it becomes difficult to save that life. And at that immediate time, you have to perform surgical cric, so it has to get the connectivity for the oxygen to go inside the patient's lung. Now I would like to invite Dr. Avniendra Bharadwaja from my department to proceed with the case. Sir, this is going to be a different presentation, but we will cover everything in that. So not will be the routine one which we are doing, because this is something which we underwent and saw with the patient.
Dr. Rishika, we will have to see our preparedness for an unfortunate event like Hathras happening in a nearby area tomorrow. So this is not the forum. Maybe we should sit with the medical director and see if something like that happens, what are we doing?
Sure, sure.
Thank you, ma'am. Good morning, everyone. I am Dr. Avniendra Bharadwaja, first year resident from the Department of Emergency Medicine, and today we will be discussing a case of a 65-year-old male who was a resident of Tutor. He presented to our emergency department with complaints of chest pain, anxiousness, sweating, and difficulty in breathing. His initial vitals were noted, which were pulse of 36 beats per minute, BP was 80/40, and saturation of 80% on room air. So according to his vitals and his chief complaints, we triaged him as red. A quick brief history was taken, in which the chest pain was sudden in onset, gradually progressive, substernal, and patient described it as having a feeling, a band across his chest. It was radiating to his left arm and jaw, which was associated with profuse sweating and anxiousness. There were no aggravating or relieving factors, and all these complaints have been going on since 2 hours. A quick primary survey in the form of ABC was done. So in airway, the patient was talking and giving his history in his own words, so his airway was patent. In breathing, his saturation was 80% on room air, so we applied oxygen mask and started him on 50 liter per minute. In circulation, his blood pressure was 80/40, so we secured 2 IV line large bore cannulas and started with IV fluids. And then immediately an ECG was done. The question to the audience: is this ECG normal? Can anybody tell, is there any abnormality in this ECG? Very rightly pointed out by sir. Thank you so much, sir. So, sir, as correctly pointed out, we can appreciate ST elevation in leads 2, 3 and AVF, which are the inferior leads, which are suggestive of inferior wall ST elevation myocardial infarction, along with reciprocal changes in the lateral leads 1 and AVF. And also one more thing to be seen here is not every T wave is followed by the QRS complex. So this ECG is suggestive of inferior wall ST elevation MI with complete atrioventricular block. So a diagnosis of acute coronary syndrome, ST elevation myocardial infarction of the inferior wall with complete atrioventricular block and symptomatic bradycardia was made in the emergency department. So what did we do for this? First of all, we connected the patient to a defibrillator, gave the loading dose of aspirin, clopidogrel and rovastatin, and injected 4,000 international units of heparin. Along with the IV fluids were kept running. So we have taken care of the acute coronary syndrome part. Now for symptomatic bradycardia, what did we do? We followed the ACLS protocol for the bradycardia part. So which suggests if the heart rate is less than 50 and the patient is symptomatic, we have to start with transcutaneous pacing. This is exactly what we did in our case. We were getting the patient ready to start on transcutaneous pacing, but then when we had a look at our patient, he was unresponsive. His central pulse were not palpable, and the rhythm on the monitor was this. Again, question to the audience. Please identify this rhythm and what would be our next step. This rhythm would be the patient's central pulse is absent and there is some electrical activity. Yes, somebody is mumbled very well, correct. This is pulseless electrical activity, which is exactly the name suggests. There is no pulse, but there is still some electrical activity in the heart. So, what would be our next step? To follow the ACLS guidelines. So, this is what we did. We followed the ACLS guidelines for the asystole and pulseless electrical activity, which suggests we have to start CPR immediately and give first shot of adrenaline as soon as possible and then reassess after 2 minutes. And this is what we did in our case. We started CPR, gave first shot of adrenaline and also established at an advanced airway. After 2 minutes, we reassessed. The pulse were not present. And the rhythm on the monitor was this. Again, question to the audience. What is this rhythm? And what do we do next? Please say loudly, you are right. Ventricular fibrillation, that is correct. What is ventricular fibrillation? Chaotic activity on the ECG monitor with no differentiation of PQRS complexes or waves. So what do we do for this? We again go to the ACLS protocol and this time we shift our attention to the shockable rhythms which are ventricular fibrillation and pulseless ventricular tachycardia, which suggests we have to give the first shock immediately, continue CPR for 2 minutes, then reassess after 2 minutes. If the rhythm remains shockable, then give the second shock and along with the dose of adrenaline. Then continue CPR. After 2 minutes, reassess. If the rhythm remains shockable, again give the shock and this time with amiodarone loading dose. So this is exactly what we did in our case. We gave our first shock and continued CPR. After 2 minutes, we reassessed the rhythm, which was again ventricular fibrillation with no pulse, and we gave our second shock with adrenaline. After 2 minutes, we again reassessed. No pulses were palpable. And the rhythm was again VF. We gave a third shock along with amiodarone, 300 mg, and CPR was continued. After 2 minutes, that is 8 minutes into CPR, central pulses were again not palpable. And the rhythm was again VF. So we gave our fourth shock, continued CPR. 10 minutes into CPR, pulses not palpable. Rhythm still VF. What do? We give our fifth shock along with half dose of amiodarone. After 2 minutes, that is 12 minutes into CPR, central pulses still not palpable. Rhythm still ventricular fibrillation. Sixth DC shock was administered at this moment. CPR was continued. After 2 minutes, 14 minutes into CPR, central pulse are still not palpable. Rhythm again VF. What do we do now in this situation? Let's take a step back and recapitulate what we have done till now. So the patient is still in VF, which is refractory now. We have given 7 cycles of CPR. in which we have given 4 shots of adrenaline and 2 doses of amiodarone and total 6 DC shocks. And the ACLS protocol has been meticulously followed. What do we do now? Coming back to our case, for this refractory we went on a road which was less traveled, and a rarely used technique which is known as double sequential external defibrillation. So the details of which will now be discussed by my senior Dr. Nikhil Pareek.
Two things. You said that pulses, even central pulses are not palpable, but you said that the BP was 80/40.
Yeah, so that was on the initial presentation.
So initially pulses were there.
Yes, sir. Initially pulses were there. Central was there. Patient was talking in his own language. Then as we were going for, he was in symptomatic bradycardia, so we were going for pacing. Then he collapsed.
And second, all these 14 minutes, it's the emergency medicine team without cardiology.
Yes, sir. Emergency medicine. So
I would request Deepesh to congratulate them. They did all this.
What about like thrombolysis or coronary angiogram in primary intervention?
So first of all, our patient
Because
is...
we have an equivocal hyperacute inferior myocardial infarction.
Yes, sir.
So you plan that after stabilization?
After, yes, sir. First of all, our primary need is to stabilize the patient, get him back to life at least.
Thank you, Dr. Avniendra. So before we proceed to the further part, first of all, I would like to ask audience, does anyone knows what is double sequential external defibrillation? Anyone from the audience? No problem. In double sequential external defibrillation, 2 sets of defibrillators are used. Pads are placed on the patient's chest in an anterior lateral and anterior posterior configuration. When the defibrillators are discharged almost simultaneously, the heart receives a higher energy of shock, which can be more effective in certain cases of refractory ventricular arrhythmia. So we did the same thing. Keeping this concept in mind, we delivered double sequential external defibrillation in our case and continued the chest compressions for the 2 minutes. So moving further, again after 2 minutes of CPR, we analyzed the rhythm. But to our despair and discouragement this time also, his central pulse was still not palpable and rhythm was still ventricular fibrillation. So, can anybody please help me what we do now? How we proceed further with this case? Let's take a step back and summarize whatever we have done now. We have a patient who presented to us with an inferior wall MI. It is ST elevation MI and complete atrioventricular block. He went into pulseless electrical activity while we were preparing him for transcutaneous pacing, and further after 1 cycle of CPR he went into ventricular fibrillation, which was reflected to all the mechanical, pharmacological and electrical methods we have used in the ER till now. The clock is ticking, the time is running, we are running out of time, and so how to calm this storm? The question arises, how to calm this storm? Any suggestions from the audience? We are dealing with these patients in critical areas. So coming to our case, at this very moment we decided to give this patient an ultrasound guided stellate ganglion block. Why we choose to give this and how we did the procedure? Before proceeding to this part, I would first like to invite Dr. Rishika Kamra from Department of Anatomy to briefly tell us about the anatomy and applied aspects of the stellate ganglion.
Thank you, Dr. Nikhil. Good morning, everyone. Given that the emergency department has opted stellate ganglion block as a treatment modality, let us focus on its anatomy. So what is ganglia? Ganglia are the clusters of nerve cell bodies located outside the central nervous system. So mainly we have 2 types of ganglia in our body, which are sensory and autonomic. Sensory ganglia carries information from receives information from CNS and carries it to the periphery, whereas autonomic ganglia is actions vice versa. It includes sympathetic and parasympathetic ganglia. Now, what is sympathetic chain? It comprises exclusively of the efferent neurons, which divides into right and left sympathetic chains and runs paravertebrally from the base of the skull to the cortex. And the ganglia which are present in this sympathetic chain are referred to as sympathetic chain ganglia. So, according to the position they are present in, they are divided into cervical, thoracic, lumbar, and sacral ganglia. Now, we'll focus on the cervical sympathetic trunk. We'll talk about its location. It is located in the front of transverse processes of the cervical vertebra and neck of the first rib, and behind the first part of the subclavian artery and the vertebral artery. The cervical sympathetic trunk comprises of 3 ganglia, which are superior, middle, and inferior. Now we'll focus on the inferior sympathetic trunk. The inferior cervical ganglia is combined with the first thoracic ganglion, forming the cervicothoracic ganglion, which is also known as stellate ganglion. Stellate ganglion block can be used under following medical conditions, which are post-herpetic neuralgia, Horner syndrome, Raynaud's disease, atypical chest pain, and refractory cardiac arrhythmia. As refractory cardiac arrhythmia is one of the strong indications of stellate ganglion block, the emergency department has opted for this procedure. Now I would like to call Dr. Nikhil to explain the procedure in detail. Thank you.
So the stellate ganglion block is an emerging intervention rarely used in emergency department aimed at breaking the refractory cycle and restoring normal cardiac rhythm. As Dr. Rishika has told in her slides that stellate ganglion is a part of autonomic nervous system which supplies to the heart, and this technique involves injecting a local anesthetic around the stellate ganglion which can modulate the autonomic nervous system by reducing the sympathetic outflow and thus stabilizing the heart's electrical activity. We did the same in our case. We did ultrasound guided stellate ganglion block. High frequency linear probe is placed transversely on the neck and at the level of precoid cartilage. Then the probe is moved laterally towards the left side and at the level of sternocleidomastoid muscles, where we can easily visualize the anatomical structures as represented in this picture. You can appreciate this is C6 C6 vertebra. The paravertebral fascia is highlighted by the blue color. We can see carotid artery over here. C6 nerve root lying adjacent to the C6 vertebra. Anterior scalene muscle and longus colli muscles are highlighted in the red part. And this is the location where we deposit the drug for stellate ganglion block. We approach from lateral to medially by needle and we deposit the drug over here. We did the same thing in our case. We inserted the needle parallel to the long axis of the probe, piercing anterior scalene muscle, ensuring continuous visualization of the needle tip as it approaches the stellate ganglion. First we did hydrodissection with 1 ml of normal saline and then administered 8 ml of 2% lignocaine. And here we are at the right place. We can see the part of stellate ganglion floating in the anesthetic medium. So after giving 2 minutes of CPR again.
Yes.
Yes.
So the CPR has to be continued because you have to maintain some flow to the brain, right?
Yes.
Otherwise, there is no point if you have a hypoxic encephalopathic patient. And when that movement is going on, then how do you kind of...
So we gave the block with the minimal interruption of chest compression. This procedure was done within a time of 10 seconds. By the time we placed the probe, we were continuing with our CPRs, and when we inserted the needle, at that time only we stopped the CPR in that patient, and then we did the procedure within 10 seconds under ultrasound guidance, and then we started the compression cycle after that. So after 2 minutes, this time to our great relief and respite, we had a pulse and a non-lethal rhythm on our monitor. And this feeling, is something very hard to describe for us. It is like a screaming yes moment for us. It is like a high-five moment for us. Ladies and gentlemen, we have achieved ROSC of this patient in the ER. And this is not the first time we have done this, but with the great pride, we can share a story of resilience, expertise backed by enough evidence performed at our center, and to our best of this knowledge, this is the first successful stellate ganglion block placed in case of cardiac arrest in any emergency department of Rajasthan state. So left sided only single side, left sided we get the skeletal bleeding. Yeah. So yes, sir, this was sufficient in our case. Some studies also suggest if it is failed, you can try right side also. So but in our case it was sufficient in the left side.
Try other side also?
No sir, we just gave only the left sided skeletal. Yes sir, in our case it was sufficient, we have reverted back the patient to the
Well, you could get it, it is fine. Otherwise, important things to be highlighted here is that it's not a new technique, it's a well-known technique, but it is worth congratulating that it was used in an emergency setup. See, routinely patients with intractable ventricular fibrillation, few of them they come. In fact, if you may recall, a couple of patients we have done. But they are done in the OR setup. Doing it in emergency setup, in the middle of a refractory cardiac arrest due to myocardial infarction, intractable ventricular fibrillation, and achieving ROSC without any cerebral damage is worth congratulating and a remarkable performance. You, as Dr. Hemant pointed out, you did not mention about how you continued oxygenation after the patient slumped into hypotension and the blood pressure decreased beyond and lesser than the. So I hope you must have done it, and that's why you were able to maintain it like that. And mostly it is the bilateral block which will be required, but if you could do it, it is fine.
Yes, sir, we have established the area. Sir, can you go?
So I have another question. When the patient came, the patient had complete heart block at that time, so and symptomatic bradycardia. Was that not an indication of temporary pacemaker at that time?
Yes, sir. We were applying the patient with the transcutaneous pacemaker. By the time we applied, we were preparing he
Went into BF.
So to summarize our efforts till now, our team initiated chest compressions on time, secured airway, performed 8 rigorous cycles of chest compressions. The patient was administered with 6 defibrillations, and the ACLS protocol was followed meticulously. And when traditional methods were not enough, we turned to double sequential external defibrillation, and our team performed a stellate ganglion block, which played a pivotal role in revival of this patient. Everything you see on this slide was done within 18 minutes. So, moving further, we took a 12-lead ECG of this patient after ROSC. So, this was suggestive of ST elevation in inferior leads, with ST depression in lateral leads, and every P was not followed by QRS. So, this is the spot diagnosis for audience. What is this rhythm suggestive of? It's a inferior wall MI with complete heart block, 3rd degree atrioventricular block. Moving to post-cardiac arrest care, the patient is now taken on mechanical ventilation support with a respiratory rate of 12 per minute. Transcutaneous pacing was initiated now at 17 beats per minute. He was taken on vasopressor support. Injection noradrenaline infusion was started at 8 ml per hour. His MAP was achieved at 70 millimeter of mercury, and targeted temperature management was initiated at 34 degrees Celsius by infusing saline, and cardiology team was informed over here. So by the time we were preparing this patient to shift for cath lab, we took a brief history from his brother. So patient was apparently asymptomatic 2 hours back, who presented to our ER with a complaint of sudden chest pain, anxiousness, sweating, difficulty in breathing, for which he consulted at a primary healthcare center. A 12-lead ECG was done over there, which was suggestive of junctional rhythm with ST changes in inferior leads. So, patient had the chest pain with characteristic of sudden onset chest pain, gradually progressive, sustained location, feeling heaviness across the chest, radiating left arm, associated with profuse sweating, anxiousness, and no aggravating or relieving factors. His difficulty in breathing was classified as NYHA class 4 at that time. Patient was on case of hypertension, diabetes mellitus since last 5 years. He was on regular medication for that. His personal history was not significant. Patient's general physical examination was within normal limit apart from RBS, his random blood sugar was 230 milligram per deciliter. His GCS before shifting to the cath recovery was E2, VT, M5 with pupils for MM bilateral equal and reactive, and rest all the other systemic examinations were normal. So the patient shifted to cath recovery under supervision and his total duration of stay in our ER was 35 minutes to that. Now I would like to invite Dr. Bhartesh Sethiya from Department of Cardiology to further discuss about the definitive management of this patient.
Patient is in the cath lab intubated state with post-loss status, with post-state ganglion block administration with the following vitals of pulse rate around 70 beats per minute pace rhythm, BP 90/60 into HM respiratory support, SpO2 94% on 90% SpO2 by mechanical ventilation, and transfusion chasing was going on. Loading dose already given the ER. The ECG on arrival in ER was suggestive of complete heart block with infibol MI. But when we reached the patient in the cath lab, the patient have sinus rhythm with intermittent CHP. The bedside 2D screening was done with suggestive of the ejection fraction around 60% of the patient. No region wall motion abnormality present. No mitral ligation and tachypnea seen. Intra-atrial septum and interventricular septum intact. No pericardial diffusion seen. The patient was taken in the cath lab with temporary pacemaker was inserted by the transfemoral venous route. CAG was done by the right radial route, suggestive of single vessel disease, 100% thrombotic occurs in the proximal RCA. So the RCA was the main culprit vessel. The patient was also having the frequent NSVT runs during the procedure. As we know, the patient have defective VT. So the cause of VT, the patient with CHB. First one, the ischemia itself, the cause of VT in the patient with CHB. Second one, RONT phenomena. As we know, the infibol MI cause the obstruction of the RCA, which lead to the decrease the AV node perfusion, and which lead to the CHB, and CHB lead to bradycardia, and this bradycardia lead to the frequent VPCs fall on the T wave of the patient, which lead to the RONT phenomena, which lead to the VT, and may this lead to the degeneration of the VF. The metabolic causes like hypokalemia, hypomagnesemia, and hypocalcemia, all three causes the long QTs, which lead to the RONT phenomena, which lead to the VTs. Some drugs cause the QT prolongation by which the VT occurs due to RONT phenomena. And when the ischemia is sustained and prolonged for a long time, this causes the monomorph VTs. And for these VTs, we require lifelong antiarrhythmic drugs, or patient may require automated intracardiac device, defibrillators. So, how to manage the defective VTs? First one, like pulseless VT and VF. We have to do desynchronized cardioversion, but other than these two, we require synchronized cardioversion, because if the refractivity is with monomer like monomer VTs, we have to do if patient is stable and patient have normal BP and pulse, so patient must have synchronized, patient must receive synchronized cardioversion. If we do things, if we do desynchronized, this lead to the again patient into VT because of RONT phenomena. The TPI, the high rate setting on TPI, as we know, the patient is known in the case of defectivity, so we have to put the TPI on higher side because it decreases the VPC burden, and when the VPC burden decreases, there is least chance for RONT phenomena which lead to the VTs. The increased use, as we know, the shock, the numbers of shock increases, which help in prevent the VTs. Injection lignocaine is a type 1A antiarrhythmic drug which help in reduce the chances of the VT. Correct the metabolic causes, as we already know, hypocalcemia, hypomagnesemia, and hypokalemia should be corrected. Amiodarone is a drug which is used for the VT, but not used in the patient with long QT VTs. Sedation also helps in the reduce the VTs because they decrease the sympathetic outflow. And the state ganglion block already told by the Dr. Nikhil. But the most important thing, treat the primary cause. So the precautions to be taken to prevent the VT during the procedure. First one, the TPI insertion and setting the heart rate on higher side. Already told because this decrease the chances for the VPCs, which lead to the decrease the chance for the VTs. And keep the potassium level above 4.5 mg per liter. Correct the magnesium and calcium, and injection of lignocaine IV infusion and sedation also given to the patient. And this is the fluoroscopic view suggestive of proximal thrombotic occlusion of the RCA 100%, and the TPI lead placed in RV. The patient was then loaded with when we see the angiography, then again patient loaded with the ticagrelor 180 mg. Thrombosuction catheter used for the aspiration of thrombus from the RCA because of the high thrombotic burden in the RCA. There is a thrombosuction catheter we used in this patient, and then the primary PTC to RCA was done with a 3.5 into 32 millimeter dry luting stent was done. And these are the clots which retire from the RCA with the help of thrombosuction catheter. And after this procedure, TIMI3 flow achieved and myocardial burst grade 3 seen. These two parameters suggestive of the good myocardial perfusion occur after the stenting. The patient was then shifted to the CCU for further management and monitoring, and patient was extubated on the next day afternoon. So these are fluoroscopic view suggestive of there is a PTC wire crossed the lesion. This is a stent placed in the proximal RCA and inflated. The check should taken, TIMI3 flow achieved. The patient was also in CCU for 2 days, and after the immense effort from the emergency department and cardiology team, the patient was discharged in a stable condition with no neurofocal deficit. On discharging medicine, patient on dual antiplatelets with high dose statin with beta blockers, and patient is a known case of diabetes, so oral hypoglycemic.
Good morning to all. As we all saw, it was a roller coaster ride for both our emergency team and our patient. So let us discuss one by one the techniques, seldom techniques used by us, which we use against the standard guidelines of the ACLS to rescue our patient. So in the coming few slides, my objectives will be: what is refractory ventricular arrhythmia, what are the different management strategies to prevent the refractory ventricular arrhythmia, and a brief about double sequential external defibrillation and the role of stellate ganglion block in the treatment of refractory ventricular arrhythmia, and thus what are the suggesting literatures regarding these two techniques. The refractory ventricular arrhythmia is an occurrence of 3 or more episodes of ventricular fibrillation or ventricular tachycardia within 24 hours, or sustained ventricular fibrillation or ventricular tachycardia refractory to 3 or more shocks, and a patient with implantable cardioverter defibrillator, 3 or more therapies for ventricular tachyarrhythmia within 24 hours. So these are the strategies for the management, which are double sequential external defibrillation, stellate ganglion block, and extracorporeal CPR. These 3 methods can be used in the emergent situation only in a patient with cardiac arrest, and rest to a surgical sympathectomy, radiofrequency ablation. These are the elective procedures which we can't do in an emergency situation. So double sequential external defibrillation has already been discussed by my colleague Dr. Nikhil Pareek. So it's an application and administration of electric current from 2 defibrillator devices to a single patient experiencing a single type of lethal dysarrhythmia during cardiac arrest. That is known as refractory ventricular fibrillation. So they are suggesting some literatures regarding the evidence of double sequential external defibrillation. This is the DOGE VF trial, that is double sequential external defibrillation for refractory ventricular fibrillation, done in 2020, published in BMC Journal. There total of 152 patients were enrolled, and they were divided into 3 categories, that is double sequential external defibrillation, vector change, and the standard defibrillation. And what they conclude was return of spontaneous circulation was achieved more in the double sequential external defibrillation, that is 40% as compared to the other methods like standard defibrillation, which we routinely use. Another study was published in NEJM in 2022 regarding the defibrillation strategies for refractory ventricular fibrillation. This study was in this study a total of 405 patients were enrolled, and again they were divided into 3 separate groups: DSAD, vector change, and standard defibrillation. And what they conclude was the survival to discharge was more in the double sequential, who received double sequential external defibrillation, that is around 30.4% as compared to the standard defibrillation, that was only 13.3%. The next is stellate ganglion block. As we all know, the stellate ganglion block is routinely used by the pain medicine and anesthesiologists and for the management of the pain. But this technique has a breakthrough in the treatment of refractory ventricular arrhythmia in the emergency situation, mainly in the cardiac arrest patient. So these are the suggesting evidence regarding the use of stellate ganglion block in the emergency department. So a meta-analysis study was done in 2017. This study was relevant because they had taken a few case series from January 1960 to May 2017. So in this study, only 35 patients they took only 35 patients for the treatment of ventricular arrhythmia, in which they had given the stellate ganglion block. So they had given both the unilateral stellate ganglion block and the bilateral stellate ganglion block, and they suggested that there was a significant reduction of in the refractory ventricular arrhythmia burden by the use of stellate ganglion block either unilaterally or bilaterally. Another case was reported in the American Journal of Emergency Medicine, which was recently published in 2024, done by the AIIMS Delhi, in which they conclude that refractory ventricular arrhythmia can be successfully treated by the ultrasound-guided stellate ganglion block. So the stellate ganglion block is an emergent technique in the emergency department in patients with refractory ventricular arrhythmia with out-of-hospital cardiac arrest or in-hospital cardiac arrest. So to conclude, in this case, we unmasked a silent threat which was fatal and had left us in abyss. So as to what to do with while applying all the conventional ways, thinking out of the box and the awareness of the new technique enabled us to basically save a lost life. So this is a video in the patient words.
मेरा नाम मोहम्मद इस्लाम, मैं कोई मालपुरा का रहने वाला हूँ और 22 मई को 22 मई को मेरे को हार्ट अटैक हुआ था, तो उसके अंदर मुझे जयपुर रेफर किए, तो वहाँ जयपुर के अंदर महात्मा गांधी और हॉस्पिटल के डॉक्टर और नर्सिंग स्टाफ ने अच्छी तरह से मेरी देखभाल करके मेरे को पूर्ण जन्म दिलवाया। अल्लाह का हुक्म था और स्टाफ की अच्छा योगदान रहा, तो मैं तो चला गया था, लेकिन डॉक्टरों के सहयोग से वापस पुनर्जीवन हुआ। डॉक्टरों को मैं बहुत बहुत धन्यवाद देता हूँ, नर्सिंग को बहुत बहुत धन्यवाद।
Just a take-home message for all the residents who have been working day now. This is a moment, especially in the case of a CPR, where you should all maintain your calm. As whenever you are doing chest compressions or whenever you are doing dealing with the critically ill patients. Sometimes new innovations, thinking beyond your conventional methods, you can give remarkable results, save as many lives as possible. And one should always embrace the unexpected. You do not know what surprise is going to be there with you. So trust your ability to adapt, and it could all make the difference in the patient's life. You can save as many lives as possible. Last but not the least, my sincere gratitude to the management of MGUMST for giving us the platform to perform and to share our stories with you here. CCR Review Committee for their continuous guidance. Department of Anatomy to collaborate with us and give us the overview of what we did. Department of Cardiology, I would like to thank them because they have been working with us 24 hours round the clock. The lab is going on, and we are dealing with such kind of patients every day. It's not that this was the only one, because we have performed stellate ganglion block, but otherwise also whenever the patient comes with the cardiac arrest, we perform and we achieve that loss. Then we send them to the cardiology lab and they do the definitive management. So hats off to them, they are working endlessly for 24 hours. Patients and relatives, because without them, for keeping faith in our institute and coming and getting treated out there. The supporting staff overall in the department here also who are managing this CCR, the technicians on duty, and above all of you for patiently hearing and working together to save the lives. Thank you so much.